Nabila, thank you for inviting me to moderate this webinar with Dr. Patrick Trevidic. Hello, everyone. I'm very happy to welcome you in the second part of our webinar of vascular complications. Sunday, we had a huge success with the first part, which was the prevention. And today, Dr. Patrick Trevidic will talk about how to recognize and treat the complications. So I think we will need to see your slides of introduction, Patrick, if you don't mind, just to, I know no need to introduce you, but maybe for those who are joining us for the first time, just to tell you that Dr. Patrick Trevidic is a plastic and reconstructive aesthetic surgeon in Paris. He's the chairman of the reconstructive plastic surgery unit at Hospital Sainte-Anne in Paris. And he is also the scientific director of Expert to Expert Group. And he worked and directed and published 5 books with Expert to Expert book. We will see all the books during these webinars, but the last one was about the fillers complication. So Dr. Patrick Trevidic has published 57 articles in addition as all his presentation in international congresses. So now it's my pleasure to welcome you, Patrick, and to let us talk about how to recognize and treat vascular complication. Thank you, Patrick.
Thank you, Nabila. Thank you for this warm welcome and hello everybody. Hope everybody's safe and locked down during this COVID. So this is the second part of my talk, and like with Netflix, I will summarize the season 1 that we did on Saturday. So if you want to review the last webinar, you can ask to Nabila and Angela the link with the YouTube TV of Teoxane just to review, the last webinar. So today it will not be about the prevention, it will be to recognize and treat. This is the 2 steps we need to do when we have vascular compromise. Remember, anything can happen. You can have a black mom and a white dad, and you can have this kind of children. So everything can happen when you do an injection. And so you need to be open-minded that you can have this kind of complication. And because we need to summarize the previous season on our, Teoxane Netflix, it's not a compression, please. Don't speak about the compression. We have a lot of articles published that it's an embolism of HA inside the artery that give, the vascular compromise. It's not a compression and it's not a vein embolism. And you will have to first to prevent, but if such things, happen, you need to recognize and you need to treat. There is a way to prevent is to do not only a good and deep knowledge anatomy, but the way to inject, the way your technique also could be a factor that will create this vascular embolism. It's always underestimated because sometimes you didn't report, this adverse event, but trust me, you have to, because if we want to have reliable statistics to get, a good protocol of treatment, we need to have all the reporting of this adverse event. And in this case, you will see we have a lack of evidence-based medicine. It means we have too much what I call a copy-paste syndrome. It means people who copy-paste and tell on the stage things they read but are not clearly reliable. So be very careful that you need to prove what you say on stage, and so go to the evidence-based medicine, and you will see that we don't have all the elements to treat, you know, such patients. So recognize the clinical sign. It's an emergency. And in case of, if you have any doubts, you have to get an action. You have to treat. And we have a tool right today that is very, very, very nice. It's a selfie. The patient can send you a selfie if you have any doubt to see an image of their face. But always, if you have an adverse event, consider this adverse event as a serious one, because the consequences could be very high for your patients. And so it will be also high consequences for you and your practice. Time. There is a big question of time. Look at this publication in 2011. It was a very nice publication by Kim on rabbits. He showed that if you use hyaluronidase, you need to use it very early after you did this vascular compromise. And he said there is no benefit of hyaluronidase injection after 24 hours. And this is for skin. This is not for blindness. So time will be very important for you. Time, you see here, it's a newest, publication done by Zoom in 2015, show that if you do a combination of treatment and you treat with hyaluronidase before 2 days, even after 2 days after your injection, you can have a recovery, as you can see here at the top. But below, it was after 2 days, and you have sequela here with scars. So time is very, very important for you, very important for your patient. So don't lose time. And because we have the selfie, even if the patient is not there, even if she's going back to her city, perhaps you know somebody there that can do the emergency treatment just to recover without any sequela. Recognize the sign. Please, don't reinvent the wheel. We have enough data now to recognize the clinical signs. And the first who publish, it's vascular surgeon. Vascular surgeon, they deal with this embolism in the artery for more than 100, 200 years. So they follow patients that had, embolism, arterial embolism in the legs. And so they have the same sign if it is an embolism in the face. So you see that this clinical sign could be totally different if you are in front of a young patient with a big embolism or an elderly patient with a small embolism. So it's for that we could have different signs of vascular compromise after HA injection because of that. So don't reinvent the wheel. Recognize the sign. This is the different sign. We have 5 steps. And we will see each of these 5 steps one after the others. So you can call these steps as you want. You can find your own vocabulary, but it's always the same. When you block an artery, you have pain. And you have immediately with pain, you have the whitening or the blanching of the area where the HA clot stopped the vessel flow, the blood flow. Then after, few minutes after, during hours and days, you have the livedo reticularis. Then the livedo increase and become blue and gray. Then after, you have the pimple phase with the demarcation of your embolism site. And then at the end, you have the ulceration and the wound healing. And if I want to add a sixth one, it will be the recovery time during all the year following your adverse event to have, you know, the quality of the scar if you have scars after such event. So first, blanching. Blanching is because the blood flow reduced. It's always there, but you don't see it a lot of time. Why you don't see it? Trust me, I had one vascular embolism on the stage during a live demo. And during this live demo, we had the possibility to record, you know, the video. So I had a high resolution video of my own vascular embolism. And if you look at this video, you will not see immediately the blanching. And why? It's because we forget something. First, because of your light. Because when you do something, when you are in your office, you have the light above you. And so to see the blanching, it's not so easy. And to think that it is a blanching because you have a vascular compromise, it's not so easy. And moreover, if you did an anesthesia before with adrenaline, perhaps it's not so easy to see. But mainly it's not for that. It's not because of the light. It's because you remember my tree. When you have a vascular compromise, you work, you know, here. You work in one place where you do your injection of HA. But you remember that the site of the whitening, the site of the blanching, is not where you are doing your injection. It's somewhere away from your site. So you are not looking always to all the face to discover, you know, a blanching area on the face. And here you have a picture from our last book on complication, where you see the blanching of this patient immediately after an injection in the nasolabial fold. And all this area of blanching is the area that you have because of the blood flow that reduces and because of your HA embolism. And this follow, you remember this publication, a very nice publication by Ashton on your angiosome. And this angiosome is very important because it's always the same pattern of your skin necrosis. So this is what we call the Pope hat sign. And the pain, you remember you have two immediate clinical signs. First, the blanching. You don't see it because it's far away from your site and because you have the light. But the pain, people always repeat, perhaps it's not there because we have local anesthetic inside the product. No, no. This is a copy-paste syndrome. You copy what the others say. It's just a false idea because the Lido inside the HA couldn't give an anesthesia of all the area where you have the vascular compromise. So it's pathognomonic, the pain. All the vascular embolism has pain, but sometimes this pain is not very high because you remember from our vascular surgeons, colleagues, that they could have weak signs because it's elderly patients who get some anastomosis in this area and less pain. So think that if you have a big pain in a young patient and it lasts, be very careful. Keep your patient in your office. Ask the patient to send in few hours after a selfie to see what happens to the color of your skin. Why? Because the next step will be the livedo reticularis. What is the livedo reticularis? This is something that happened in dermatology, very well known, described by Ebra. And this is a purplish discoloration of the skin. And it's a vasospastic answer of the micro vessels to cold, to some reduction of the blood flow in the angiosome. So let's go back to the explanation to understand why we have, this whitening spot and I will say purple spot around. So why we have this pattern of the livedo? It's not interesting for you, but because we have a webinar, it's for me, a way to understand what happens. Look at that. You remember, all our skin, it's pieces of skin, each close to another. This is the angiosome. It means it's a part of the skin that has its own vascularization, and the surface of this angiosome in our face has a length of 4 centimeters and a width of 1 centimeter. And so you have to connect these different angiosomes. You remember our last webinar, you have true anastomosis, that is not really the first one, but we have shock anastomosis that could open if you have, for example, some issue in one angiosome to bring the vascularization through this anastomosis here and to get a good vascularization. But because with vascular embolism, we have an inflammatory process and we have a spasm, these choke vessels, remain closed. And so this territory will have less blood flow inside. So it means it will give you a size of 1 to 4, a spot of pale skin, of white skin, but around this spot, around this angiosome, you have a lack of venous drainage. And so this brings to you the purple color of your patient. So look at this patient. He has a typical livedo reticularis 4 hours after a new fill injection in the fascial artery. And you see what happens. You have vascular embolism in the big vessels. Choke vessels didn't open. And so you have white part. This is the white part here. And you have bluish aspect of the skin around. So this is the livedo reticularis. And this sign will last from 1-2 hours after your event until few days after. So this is an example of what happens, with your patient if you let the livedo here going to the blue-gray phase, as you can see here. It's 1 or 2 days after. So the coloration become much more darker because you have a venous congestion. So this is the second phase of your patient. And after, if you let your patient without any treatments, you arrive to the pimple phase, whatever the name. You have here spot of necrosis after this blue-gray phase here. So you have vesicles, you have crust, and this aspect is not an herpes disease, but it's really a vascular compromise. Why it's not an herpes disease? Because it's not the same location that usually the patient has, and it's not the same aspect because you get, you know, this coloration before. So you have the story, the location, the site, and you see that this, you know, will give the last phase, that is the ulceration after the pimple phase. This is the ulceration phase with the secondary wound healing, and you will have a color of your skin a little bit more blue, like a scar. And if you follow your patients all along the year after, you can see one of my patients here with a necrosis of the forehead, and you see this patient 1 year after. So you see the scar here, because for this patient, I use toxin to limit the scar, and I redo the scar. So this is the end of the process. But you see, you have sequela of your HA embolism. You want not to have this, because with this kind of extensive fascial necrosis, the sequela will be worse to your patient. So be very careful, try to limit the sequela of your patient. And I love to tell little story to my grandchildren. I have 2. And so I will tell you a little story. So this is the E2E little story book. Once upon a time, a doctor was injecting a filler, and he was doing a good job. It was a good injectors, but he forget perhaps some dangerous area. And you see, the patient, the day after, the telephone rang to his office. So he answered to the patient, and the patient say by phone, "Hey, Dr. Patrick, I call you because I got an hematoma and pain." And these doctors, in 90% of the case, because it's once upon a time, you know, a little story, he said to the patient, "Oh, don't worry, applied arnica cream or helichrys and take your painkiller, please. Thank you, and see you in 10 days. And 10 days after, with this little story, the patient come back to his office with this spot of necrosis. So be very careful. When a patient calls you, it could be like this, always the same, if you don't hear very well the bad noise behind this call. Another little story. Once upon a time, 3 days after an injection, the patient called. It is the pimple phase. And you answer, "Oh, don't worry, it's not the site where I did my injection, so you can be very quiet. You can reduce your stress." But you see 10 days after what happens, and 21 days after what happens to the patient. So you have to, when you have such story with one patient, please ask them to send a selfie. So I will, for you, do a quiz just to see if you follow what I say. So first, tell me what is on the left side of your screen here, and what is on the right side of your screen. Why? It's because you remember you didn't see the blanching and you didn't take care about the pain because you didn't discover that. So when your patient will send you a selfie, they will send you this kind of selfie. This is selfie. On the left side, you see it's non-homogeneous. There is here a pale, a whitening, a blanching aspect, and here you have a purple one. And it's not homogeneous. It's like, we call it in French, a geographic map. We call it a geographic map. So it's not with well-defined area. And this is a vascular compromise. And this, what is this? Nabila can tell you that it is an hematoma because it's really dark blue, it's well organized with limits around. There is a swelling also because there is the volume of the hematoma. So in this case, you can say like me, hey, don't boring me, put your arnica cream and take your painkiller. But for this one here on left, you will have to tell her, please come back immediately, it's an emergency. So this is the difference. Another quiz? Yes. What is this? This is an hematoma. Why? You have here a big swelling. So I think this patient has a trauma of a big vessel. And you see it's dark blue here. And when you have a vascular compromise, it's very rare that your vascular compromise is on both sides. So it's often on one side. So when you have a dark color, well limited, it's an hematoma, and it's totally different from a vascular compromise and a livedo reticularis. Look at this patient. What is that? You can have both. You can have a vascular compromise here, and you can have here an hematoma and a bruising. So be very careful. This is a livedo. This is an hematoma. So be careful. You can have both, but you see that the difference between a livedo reticularis and an hematoma, because she has also an injection in the tear trough, you can have two things joined together. And here you see, this is not an herpes disease. This is a vascular compromise. So when you see some of the selfie of your patients, when you see such things, even if it is a little bit too late, because you remember it's few days after, you have to take care about your patients. What is this? Is this an herpes? No, it's not. You see the pimple phase here with vesicular because you have some bacteria on your skin. And so these bacteria want to destroy, the necrosis. We know that in surgery with ulcers everywhere, we are used to treat, such things, but to see the difference between herpes disease and, this vascular compromise, open the mouth, you will see the skin necrosis of the mucosa too, and also the location is much, wider than the herpes disease. So Nabila, on recognize, it's your turn, and this is the poll question to see if you follow me.
Yes, Patrick, let's see the first poll on recognize. Do you see my screen?
Yes, I see your screen.
Okay, so we have 3 questions.
It's easy question. Huh? If you follow me, it's easy question, easy answer.
They are more easy than yesterday, Patrick. Huh?
Yes, 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 yes. We do during, when I am on stage, I do a big quiz where I can ask you what it is, because we have, with expert to expert, with Nabila, we have a lot of clinical cases of vascular compromise. So
Let
yeah.
me show you the answers. So it's not an emergency to recognize the vascular compromise. Of course, no. For most of you, of course, it's an emergency, Patrick, because the soonest you will recognize an adverse event, you will treat it and you will reduce the sequela. And as you said, Patrick, before, the best is before 2 days. The best, of course, is before 6 hours if you want to act with your hyaluronidase. In case of blindness, of course, realize that you have between 30 to 45 minutes to do your retrobulbar injections, because otherwise no recovery will be possible. The second question was, livedo reticularis is homogeneous and dark blue. So as you explained very well, Patrick, it's heterogeneous. So 86% of good answers. So it's heterogeneous because of these pieces where we will have venous congestion and other parts where we will have the blocked arterial cones that would be white and blue, like a marbling aspect. And then we have the last question. Pimple face looks like herpes disease without the background. Yes, it looks like it's similar, but the story is different. Do you want to add something, Patrick?
No, you're right. It's an emergency. You have to deal with your vascular compromise, and mostly if it is a blindness. Blindness is very rare, but you have to go as fast as possible, and in any doubt, you have to treat. So just to tell you that we are actually 850 attendees with us together. So thank you very much to be there. So we will go and we will treat now. So go and treat, it means when you are going to treat your patients, you will have to, you will have to be sure that you have in your pocket, this is why I use only hyaluronic acid, because I love to have in one of my pockets, you know, hyaluronic acid, and in the other pockets to have a specific antidote. There is no other fillers that allow you to get on one side the product you use, and on the other side, you get your antidote. So for me, this is a question of prevention. I love to get in one of my pockets, you know, something, and in other pockets, something I can erase. So what is the hyaluronidase? Hyaluronidase, it's an enzyme, and Carl Mayer, you know, classified this enzyme, and this enzyme hydrolyzes, you know, the HA. And we have 6 enzymes in our body. And hyaluronidase, you can find hyaluronidase, you know, in your skin everywhere, but one of the most specific is in the testes. It's because it's useful for the spermatozoid to go through the membrane. So this is why we have hyaluronidase, and this is why the hyaluronidase, many of the hyaluronidase in the market are coming from bovine or ovine testicles. So hyaluronidase has been, you know, also useful at the beginning. It was used to facilitate the local anesthesia, with also to put some liquid with a faster absorption with children. So hyaluronidase is very well known. And the first publication, it stopped in 1951, that was promoting hyaluronidase at the same time with procaine to diffuse the procaine with the wider, halo of anesthesia and a faster, anesthesia of the area of injection. And the last publication, it's in 2020, and it's on retrobulbar, hyaluronidase treatment. But in PubMed, you will find 11,500 references with hyaluronidase. So let's start what we know about hyaluronidase. Hyaluronidase, it's well known, and we are in 2020, but look at this article published by my friend Carothers from Canada. And in 2007, she said,
we cannot, Patrick, we cannot,
what?
We see a white slide, Patrick.
Wow, no, me, I have you see this slide here?
Maybe not me, I have only treat, a white slide with treat.
Nazila, do you see my?
Yes, I can only see a white slide, so I think there's an issue with the presentation.
You should
okay,
go
so I will share with you. Do you see my slide here?
Not yet.
Oh, sorry. I will do something.
I was thinking that you were doing the American way of lecturing, Patrick, just with the one slide.
I will no. I will no. I will do something. Do you see my slide here?
Yes, now it's.
Yes, perfect. Thank you so much.
Okay. So as you can see here, sorry, I will. I have an issue. Do you see it?
Yes.
Do you see my
Yes,
slide?
I can see it
Okay,
perfectly.
good.
Thank you.
So you remember we have 1,500, 11,500, PubMed references, and we know it works. And Carothers published in 2007, so it's 13 years ago, said that if you work with fillers, you have to get in your fridge hyaluronidase. So in some country, it's mandatory by law. In Germany, for example, it's mandatory by law to get vial of hyaluronidase in your fridge if you do filler injection. Just to avoid such, complication. You see the pop-out sign here, but the pop-out sign necrosis. And with the sequela here. The other treatments, trust me, you can forget. So hyperbaric oxygen, nitroglycerin paste, Viagra, lidocaine, aspirin, antibiotics, you can forget everything, because the only product that can erase a vascular compromise, it's only hyaluronidase. So in your crash card, if you have a vascular compromise, and we will see after the protocol, you need hyaluronidase only. Which hyaluronidase? It depends on your country and on your national health authority. We get in Europe only one vial in France, one product authorized in France. It's Yalaz. We had in the past Desinfiltral, and in US you see you can have everything It's coming from bovine, ovine, and there is one that is human recombinant in US. You see here the dosage, and you see if there is a reconstitution. But what you have to get in your mind is that, and this will be very important for the protocol, whatever the hyaluronidase you use, the half-life of the hyaluronidase in your body is very fast. Remember this because I will use it a little bit after. So where we need to put the hyaluronidase? So you understand, you want to treat your patient because you recognize the clinical sign. You are before 22 days after your injection. And so you will use your hyaluronidase. So you open your vial, and after, where you need to inject your product. Where you need to inject, we have a lot of answers. Because you remember the ear of the rabbits of Kim, the Korean, dermatologist. What he discovered in 2011 is that if you treat the rabbits, you can treat the rabbits after HA embolism by putting the hyaluronidase around the vessel in the subcutaneous layers. So it was not in the artery, but around. So you will tell me, but how this hyaluronidase can go to the HA clot, because the HA clot is inside the vessel. He didn't give any information about that because he didn't do some study. We had to wait the publication of Claudio Di Lorenzi that put some cadaver artery filled with HA with knots on each extremity and immersed, this in a vial on one side with hyaluronidase and on the other side with physiologic serum. And after 4 hours, he discovered that in the hyaluronidase spot, the hyaluronic acid that was in the vessel was like a liquid. It means the products, the hyaluronidase, can go through the arterial wall and reach the clot. So this is the transarterial degradation of hyaluronic acid filler. And there is another study published by Wang in 2017 that confirmed everything. It takes again the ear of the rabbit. You will tell me we use a lot of rabbits for HA clot. It's because it's easy, because in the ear of the rabbit, not like us, there is only one artery. So it's very easy to study and to take pictures. So it's for that we use rabbits in our clinical research center. So he did a HA embolism, and he showed that if he put the hyaluronidase in the site where you have the HA embolism or around the artery, it's working much more than if you do a HA injection in the artery. So he showed that is very bizarre, it's very weird, that it works more if you are around the vessel or in the site of the HA embolism than if you put your hyaluronidase in the vessel. Where is the HA clot? So people said, but why we have this? Why, if you put the hyaluronidase inside, it must be better. Why it doesn't work? It works in the artery because we have some study in the cardiac field showing that it works, the hyaluronidase, in the arteries, but not a lot. Why? It's because there is an inflammatory process first. So it's not so easy for the hyaluronidase to reach the clot of HA. But moreover, it's because of that. This is a brilliant article published in 2016. This guy, Chiang, proved that if you have an HA clot that block a vessel, immediately after, embedded with the HA clot, you have a blood clot. So what did he do? To show that this mechanism that you have in your artery plus the inflammatory process, don't forget. So you reduce the lumen and you have two clots. And what did he did? He did a double injection in the artery. And what he showed is that when he used hyaluronidase and urokinase in the artery, the group of surviving flap was 92%. And when you use only hyaluronidase, you have only half of the rats with a flap survival. So this study was amazing and proved that if you do intra-arterial injection, and you will see it's very important for the rest of my talk, that if you have a skin disease, a skin vascular compromise, you can put your hyaluronidase in the site of the compromise, or if you put in the vessel, you need to put urokinase with. What is urokinase? It's a protease. So it means it it creates a thrombolysis by activation of the plasmin. So it degrades the blood clot. And our vascular radiologists use a lot of these products. So if we are going to a specific area of the blindness, look at this, because this is also a story, a beautiful story. It's one upon a time. We have a blindness. Why we have a blindness? It's because we did an injection in the nose, first area of blindness. We inject in the nasal artery. Because of the pressure, the nasal artery is coming from the ophthalmic artery, and because of the pressure, the HA clot go backwards to the flow until it reach the retinal artery, and then follow the flow and go and give the blindness. Okay, this is the story of the blindness with HA. So people say, okay, I will do a retrobulbar injection, and you have all to learn how to do it. My ophthalmology colleagues say you are totally crazy, plastic surgeon, because retrobulbar injection can give a lot of adverse events if you don't know how to do it very easily. So a lot of doctors promote retrobulbar injection. And this guy published the latest publication about retrobulbar injection in 2019 and say it was on rats. It was 1 hour after he used a retrobulbar injection, and he said it's maybe effective. But all the rats had no recovery with retrobulbar injection. And some said no. And Zhu tests the retrobulbar injection in 2017 with high dose and say it will not reverse the blindness. Why? It's because of these two studies. With the studies, they prove that the hyaluronidase can't go through, the optic sheet around. So it means that the hyaluronidase can't reach, your retinal artery. And so when we see that, we say, okay, if we have a blindness, we can't do anything. But with expert to expert, 2 years ago, we said on stage that the only way to treat blindness was to do as fast as possible and to follow the rules of, you remember, the rats with urokinase and hyaluronidase. And thanks God, we have now, because this study proved that hyaluronidase only in the artery will not reverse, but this publication, 2020, January, we have the solution. So it's a brilliant publication. 24 patients with not always a total blindness, but with decrease of visual acuity, prove that you can improve if you do hyaluronidase and urokinase in the artery. So you see how step by step you can arrive to the treatment for each area. So this is for the blindness. So for me, blindness is an emergency because after 6 hours, it's too late. And the only way is to promote in your country the stroke centers to be at the first step of the blindness, because only stroke radiologists can do this job 24 hours, 7 days, 365 days. So you have to organize this stroke center with your help in your own country. The second question with hyaluronidase is, do we need to do a skin test? No, 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 and no. Even if there is some allergy, not with hyaluronidase, but it's with that is around hyaluronidase. It means the product in the vial contain not only hyaluronidase, but you have some compound with it. And this is a compound will give, you know, this allergy. So for the vascular compromise, don't do any skin test. And I do no more skin tests with my patients. Do I need to put some lido, like some doctors do, in the site before they do the hyaluronidase injection? Because I don't know if you use it in the past, but me, I use a lot of hyaluronidase and it's painful. So some people say, I will put lidocaine, and so like this, I will decrease the pain. And look at this study here. If you add lidocaine, the pain will increase. So unfortunately, it's a pain area where you will put your hyaluronidase, and don't put lido because it will not decrease the pain of the injection. You have drug interaction and contraindication, but in my point of view, there is known contraindication. And there is always the same silly question. If I use hyaluronidase, I will degrade my hyaluronidase, but I will degrade also my native hyaluronidase. But it's a silly question. It's a copy-paste syndrome. Why? Because you produce HA all the time. And moreover, if you degrade HA, look at this, your body will compensate and produce more de novo hyaluronic acid. This is a publication. So if you have hyaluronidase, you will perhaps immediately degrade a little bit your native HA, but your body knows what to do because your HA, your native HA, lasts normally in your body few hours to 1 day. So it will reproduce your native HA. What are the dose and the protocol we need to use? And here we are in the fog. Because we are in the fog, because there is no consensus, because we have a lack of evidence-based medicine. So I will show you where we are with expert to expert. When we do our protocol, first, never trust the speaker. So read again, try to find protocol, but never trust the speaker. My experience 10 years ago, it was with desinfiltral. And with desinfiltral, it's a Spain product with ovine, 1,500 units. I have to reconstitute this product, and we were reconstitute this product with 5 ml. And the reasoning, it was that the hyaluronidase was destroyed. You remember the half-life? I go back to my talk. Was 1 hour. So because you have to destroy and it takes time, you will have to do multiple injections. And so it's for that the recommendation of the company who sell this desinfiltral is to dilute the product. But if you dilute the product, you will have less high concentration to reach the clot. So this was the classic protocol. But me, for 2 years, my experience is with desinfiltral Yalas from Dessau, from Germany. And I use only the 1,500 pocket vial. And I dilute with 1 ml of physiologic serum. Why? Because we wrote this book in 2017, in January, with Claudio Di Lorenzi in this book with us. And Claudio Di Lorenzi published the same than in our book, what he called in July in Aesthetic Journal, the new high-dose pulse hyaluronidase protocol. This is the one I use. So I put, you know, the main part of his article here. He used only hyaluronidase. Within 2 days, with repeated injection into the ischemic tissue hourly until resolution. Now we have 3 years with expert to expert, with experience this protocol. Why you flowed the area? Why a high concentration, 1 ml of dilution? Why we put 1,500? Why we put hourly? It's because everything behind is to maintain a high level of hyaluronidase. Why? It's because you remember the half-life. And you remember that to dissolve the clots from all the tiny vessels, you need more time. So if on the other side, you dilute the product with the swelling, and you have also anti-enzyme against the hyaluronidase, you will have a very short half-life. So this is why you have to put this protocol. And the classic protocol is not working. So you look at this. This is what happens to your body. You did a HA embolism. It's going up, up, up. You block the flow. You create an area where you have the livedo reticularis, and you have around, you close the shock anastomosis. So where you will do your injection with high dose, high concentration, hourly injection. You will use a cannula, a needle, whatever you want. You mark the zone, look, like I do to this patient, of livedo reticularis, and I will inject everywhere in all the layers my 1 ml vial of hyaluronidase with, normally I use a botulinum toxin syringe to do that. So how to summarize what I do now? Don't forget the consent form. So I do like Claudio. I use only hyaluronidase in the ischemic tissue, but he put in his protocol that he will go on until the livedo will disappear. So let me show you on the right side of your screen what happens. If you do that, trust me, the bluish aspect here, it's 1 week after. So will you do during 1 week, every 3 hours, 1,500? No. Here in my protocol, I do only 3 times, and I see the patient after 12 hours to see if it works. But sometimes it doesn't work. You remember why? It's because you have the blood clot. So remember, this is to summarize the protocol. So hyaluronidase, high concentration, low dilution, and repeated high dose of hyaluronidase. So the take-home message for me, it's hyaluronidase, and it's an emergency. Thank you very much. And Nabila, it's up to you for the poll question.
Yes, Patrick. Let's go to the second poll about the treatment.
I put some funny question, Nabila. Huh?
Yes, but they have like 100 questions for you, Patrick. So get ready for the last.
I get ready, yes.
And you have a big fan club here. Also, you have a lot of.
Thank you. Thank you.
And congrats.
You know, we were almost 900. Huh? That's not bad.
Excellent. So let's see the results, Patrick. Let me show you and share with you the result. Viagra is a good medication for vascular compromise. No, maybe for other indications, but not for.
Perhaps. I hope so.
And solely hyaluronidase has proven efficacy in vascular compromise. So the answer is good, excellent. It's yes, only hyaluronidase is proven efficacy.
Yeah.
Hyaluronidase is based on ovine or bovine testicle. Yes, most of the hyaluronidase are based on bovine or ovine.
This is good.
Product. So, and the fourth question is, does clinical hyaluronidase mediated HA degradation in the management of HA overcorrection also impairs the skin physiological HA production? So here we had like 64% saying no, but you said that a little amount of natural HA can be destroyed, but it be compensated in the next 24 hours by the body.
Yeah, that's right.
Already the hyaluronidase is breaking the HA gel on small pieces that looks like the natural HA, and that's why these small pieces will dissolve in 24 hours.
Yes, and it's also because the degradation, the product of degradation of HA filler stimulates CD44 receptors and stimulate the production of new HA. And so it's for that we have, you know, the stimulation.
Yeah, so the answer also is related to the fourth one, that the application of hyaluronidase interfere with the natural aging process of the skin. So most of you answered no. Patrick, you said that hyaluronidase has an immediate effect and a half time of 2 minutes, around 2 minutes. But the duration of action is 24 to 48 hours. So normally it cannot affect the natural aging of the skin.
No, no, it couldn't. So the answer is no.
Okay, so we had excellent answers from the audience.
Yeah. So perhaps we will, in the last 10 minutes, if you have questions, Nabila?
Yes, we have a lot, Patrick. I selected most of the interesting questions, but we will answer to all the other questions by email.
Yeah.
So the first question is, the filling itself causes pain. So how can we differ it from the vascular embolism pain?
What, may you repeat,
So
please?
the pain of the injection, why this pain is different from a pain that we could have with the vascular embolism?
It's very difficult because pain is always there when you have a vascular embolism, and you can have pain because you create with your needle some bruising, some hematomas that can create pain, but you will get an alert in your brain if the pain is in another place than the place where you are injecting. So for example, you are injecting, I got one like this. I was injecting the nasolabial fold with a needle in a superficial way, and my patient say, wow. And she said to me, I have a pain in the forehead. So this is very pathognomonic of a vascular compromise. But I had another one. I had 4 vascular embolism. So I can speak of each because it's really a mess when you have vascular embolism. I had one in the lips, but this lady had a very little blanching, but I didn't see the blanching, but she had a huge pain in the area of the lips, and she had a huge pain. And normally the technique I use in the lips are not painful. So I said perhaps she had an hematoma or a bruising, but the pain lasts longer than it lasts normally. And this, you know, give me an information that perhaps I have something wrong. So in this case, if you have any doubts, keep your patient in your office just to check. And you will see that the libido after 1 or 2 hours will happen. And this will be clearer for you that you have a vascular compromise.
Patrick, we have also another interesting question. How many units of hyaluronidase can dissolve 1 ml of HA?
We have a lot of this study in vitro. It means out of any in vivo test. Why this kind of tests are not accurate? When China, that is our colleagues from Germany, did in 2009 an article published on his recommendation, it was based on in vitro tests where he proved that if you put 60 to 100 units, it's enough to dissolve 0.3 ml of products. But it is in vitro, it's not in vivo. It's not a vascular compromise where you need your hyaluronidase to cross the arterial wall. So it's for that, to know how many units we need to dissolve, you know, 1 ml of hyaluronic acid. It's not useful for a vascular compromise because the vascular compromise, it could be very, 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 very small drops who can create a big vascular embolism because the size of the vessel are very small. So it's not a question of quantity, it's a question of location of the HA in the vessels. So we don't care about how many units you need to dissolve 1 ml.
Patrick, yes, and after what time blindness can occur after vascular compromise?
Or we have publication where we have delay onset, delay blindness. It means patients who had, some pain in the eyes, and few hours after, they start to have the blindness. People say that it's perhaps because the HA clot was not complete, but because of the massage of the movement, the HA clot can move and go and block where the vessel becomes smaller. But this is hypothesis. This is not evidence-based medicine. Like people who say, if you put hyaluronidase, it can dissolve a little bit the clot in the artery, and so the clot can go, the HA clot can go further and block more, the location, the site. There is no, also, it's an hypothesis. We don't know yet what really happened, but we know that blindness could be delayed, immediate or delay. I encourage you to read an article published by the Korean Society of Ophthalmologic Doctors on 44 blindness cases, and you see all the signs about this blindness.
Thank you, Patrick. And we have another question about the use of hyaluronidase. Once you open your vial of hyaluronidase, can we store it? And if we store it, how long can we store it?
It's a good question. It's for that in my talk for vascular compromise, I said to you that I use all the vial. Like this, I will throw away an empty vial. I know that hyaluronidase is very expensive. So in France, it's very expensive. Yalas is very expensive. So some people try to keep it, and we don't have any study about that. The only study published at this moment is not with hyaluronidase, it's with botulinum toxin. We know that we can keep the botulinum toxin reconstitute in your fridge during 5 weeks with the same, effect, with the same power, and with no bacteriological modification status. But with hyaluronidase, we don't know. To tell you the truth, for vascular compromise, I use hourly 1 vial 3 times. So it means I never have to keep my vial for vascular compromise. It's different when it is an overcorrection or a misplacement of the product, but this is not the purpose of my talk today.
Thank you, Patrick. So you said that we had a clot, so why heparin and antiaggregant are not advised?
It's because heparin will not dissolve immediately remember, you want to have an immediate effect, and moreover, if it is a blindness. So if you want not to wait for the anticoagulation process to take time and to get a definitive blindness or definitive necrosis, you have to have an emergency action. And we have not to reinvent the wheel. Our colleagues in vascular surgery, in vascular neuroradiology, they use urokinase. They don't use heparin. They use heparin after to maintain, but they don't use heparin at the beginning. Same with aspirin. It's not accurate when you have vascular compromise. Aspirin is just, you know, put water on the wood, we say in French. So it means it doesn't have any action. But remember, urokinase is useful when you do an intra-arterial injection of hyaluronidase. And the only site where we have to do that, it's blindness.
Maybe, Patrick, we can add 2 more questions. What do you think?
Yes, but very fast because we have...
The first one is how to do arterial injections of urokinase and hyaluronidase to treat blindness.
To treat blindness, our neuroradiologist colleagues knows very well with microcatheter to go up when they are trained for stroke. They put microcatheter until the ophthalmic artery, and you have the retinal artery there. So it's very easy to arrive there because they are well trained. So it's for that, for me, the target for National Health Authority regarding the blindness in every country, because you need to have this center open 24 hours, 7 days, 365 days, is to get this emergency center who treat strokes and get them a protocol just to do the treatment as fast as possible. So do we need to do something in our office? I will say no. I will take my patient and bring him personally to the stroke center. But the stroke center needs to have not urokinase because they have, but they need to have hyaluronidase because they don't have hyaluronidase in the stroke center. So we have to organize that in each of the country with the intensive care management, just to have centers where they can do that.
Thank you, Patrick. The last question is, what about adding steroid to reduce the inflammatory reaction?
The inflammatory reaction, it's a reaction of the wall of the artery. It's immediate. And I think if you use corticosteroid, it will not have an action immediately. And this is an increasing factors of the vascular compromise, but your treatment will not have an action immediately. So the corticosteroid will not improve perhaps will improve your inflammatory process if you have a big one after HA embolism, but it will not treat the vascular compromise. Like aspirin can have, you know, some vasodilatation, will help, like lidocaine, but this will not help for the vascular compromise in itself.
Thank you so much, Patrick, for this amazing webinars and for answering all the questions. Thank you for everyone to be with us. We were almost 850